formative evaluations of community-based immunization programs in low and middle-income countries. And this is some work that I'm doing right now with Monica and Avantika. I'm sure everybody in the room knows them very well by now. And this is actually my first opportunity of sharing this work, even with our researchers who've been involved in carrying out these evaluations. So we'll be very happy to get your feedback here, and also we'll be reaching out to you later for more feedback as we put together the report. So I think just a quick recap. As Monica already presented in the morning, this is a program that we set up in 2015. And the scope of the program was actually set by a study that we carried out, which showed some of the findings that are listed here, which were also sort of mentioned by Monica in the morning, that interventions that are co-managed with communities are likely to be more successful. And while that is the case, we have seen very few community-based approaches being used in immunization, unlike some of the other sectors like WASH and rural development. One of the other things that the scoping study pointed out was that there's implementation capacity, which is a likely bottleneck in the delivery of interventions. So based on the scoping study that was carried out in 2015, we set up an evidence program where we funded both the formative evaluations and the impact evaluations. Formative evaluations basically to sort of understand the feasibility and acceptability of carrying out the interventions, and impact evaluations as you go about effectiveness and scalability. So why formative evaluations? This is probably one of the first windows that evidence programs in 3IE where we supported formative evaluations. Well, the need for the impact evaluation is pretty well established. We know that they look at the interventions and then assess those interventions on the impact of the intervention for the outcomes of interest. But what impact evaluations, or most of the impact evaluations that 3I is funded, what they don't do a very good job of is basically unpacking the black box of mechanisms, the mechanisms that sort of undergird this process of impact or no impact that the impact evaluations actually try to assess. And it is here that the formative evaluations actually come in to sort of tell us how these various, and the mechanisms that we listed here are just indicative. This could be a longer list of mechanisms, that's just for the illustration purpose. But mechanisms like stakeholder characteristics, intervention delivery quality, contextual level barriers and enablers, this and many others have a sort of bearing on what is going to be the relevance, feasibility and acceptability of the intervention, which then will have an effect on whether or not the program seeks an impact. So this is just a geographic spread of the formative evaluations that were funded as part of this program. We had 2 evaluations in Nigeria, 2 in Ethiopia, and 1 each in Pakistan and Myanmar. This is just sort of a quick recap, not an exhaustive description of the interventions that were evaluated as part of these evaluations. We had a set of interventions which used visual aids as reminders for immunization to caregivers, and this was the VIR bands, which were used in Nigeria and Pakistan and Ethiopia. They used the calendar, and over and above the calendar, there was also the defaulter tracing tool. Then there were interventions in Myanmar of the checklist, and Dr. Phone would be talking more about it, and the PAR intervention in Nigeria, which talked about community participation and how increased involvement of the community in the design and delivery of the intervention actually helped build greater ownership for immunization. And finally, we had a program in Ethiopia which aimed at extending the Health Development Army platform to pastoral communities. So those of you who may be familiar with the Ethiopian context, the Health Development Army as a platform has been around since 2010, 2011. And these are basically community structures of 5+1 community women who then sort of federate into higher level structures and then link up to the health structure through the health extension workers. So while this platform has been extensively used in Ethiopia for agricultural communities, it had not been tested for the acceptability and feasibility of doing it in pastoral context. So those were primarily the interventions that were evaluated. And here what I'm trying to summarize are some of the key characteristics across for all of these interventions. All the interventions that I just discussed have involved a varied level of participation of the research team. This has, like I said, there isn't like a constant, it's difficult to say that this was same across all the studies, but the level of participation that the research teams had in program design and implementation really varied, but pretty much all research teams had a role to play. Secondly, and this is something really key, all the interventions were actually delivered in close collaboration with the existing health system. And that's a point to emphasize because this was something that we wanted to make sure that we were testing and piloting for interventions that held the potential for being integrated into the health systems if they were found to be acceptable and feasible both from the community and from the provider perspective. Now, sort of delivering something in collaboration with existing health system meant that all the teams actually engaged in a strong stakeholder engagement plan, which like we say, ran wide and deep. So the teams did extensive engagement with stakeholders right from the national level up to the local level, and there were frequent touch points. So this was not like a one-off engagement, but something that went on a regular basis. This also meant that the teams had to allow or had to sort of factor in for some realignment of the plans, because when you're working with the government, you really don't have that level of control on your timelines. So you literally play by the rules of the government. Some of the other characteristics that we see in the studies that 3I supported was the implementation team and the researchers playing a significant role in sensitization and training. So this was training both of the local health workers as well as the community members, And community members is a full range, so you had traditional birth attendants, you had parents, school teachers, religious leaders. So the whole array of community members were sort of trained and sensitized on the motivations of the intervention. There was also what we found an improved monitoring and supervision, supportive supervision that was provided, which was actually very useful both in increasing the ownership by the community, but also identifying new areas of support and sort of doing more responsive programming. So, as was mentioned in the workshop yesterday, that as you discover certain gaps in your implementation, you sort of cover for those gaps as you go along, so your programming becomes more responsive. Also, because of all the data collection and data management that was happening as part of these studies, it also allowed for triangulating data between what the researchers were collecting and what the administrative data that was already out there. On the contextual barriers, these were the four. There were many more barriers and there were many context-specific barriers that some of the studies discussed. But what we've culled out here are mostly that we see mentioned by most of the studies across. And I'm sure there are no surprises here. There are issues with health-seeking behavior, and there can be various reasons that the studies identify as to why health-seeking behavior is poor in these communities. There are issues with last-mile resources. So I think in the earlier panels today, we have discussed supply-side issues and how that has implications on the demand that we have for immunization. Some studies also highlighted program management issues, program management at the government level, as well as the national level challenges where they had to deal with competing priorities. So, for example, in some countries, even though the health system was sort of bought into the idea of carrying out the pilot, the priority suddenly became polio and not other immunization that the interventions were looking at. And these contextual barriers actually get all the more aggravated when you're working with communities that like the pastoralist communities. In terms of facilitators, what most studies actually said was that they thought that there was a strong political will, so there was a well-intention in the governments to address this issue, be it of low coverage or stagnation. So we don't see in any studies where the researchers say that, well, there was really no appetite in the government for improving immunization. Similarly, in some of the contexts, at least in the Myanmar and the Nigeria context, it seemed that there was also an appetite for evidence. Even though we can't say that this was really a culture of use of evidence, there was still some merit that the policymakers saw in using evidence to improve service delivery. Then in a couple of contexts, especially in the Ethiopia context and in Pakistan, we also find that the agencies that were delivering the intervention actually had a very good standing with the government. So they had the kind of credibility and the rapport that you need to work with the country government and with the existing health systems. And the other thing that we find is that pretty much no study reported that there was lack of community trust when it came to working with health workers. In fact, some of the couple of studies actually changed their design and allowed the health worker a bigger role than they had earlier thought of, because the communities trusted to get, say, the VIR bands more from the community, from the health worker, rather than from a traditional birth attendant. So what this really led to, the kind of interventions that were supported as part of this evaluation, pretty much all the service provider, and these are perceptions that have been elicited as part of key informant interviews, focus group discussions, and overall most service providers thought that the tools that were promoted as part of these various interventions sort of helped build a dialogue. So they became very important aids around which the health extension workers could actually talk to the community. So it was not such an interaction. I think in the morning there was a mention of how the interaction with of a health extension worker is just about telling you that you need to do X, Y, Z. So it helped change that communication and made that more into a dialogue, and which sort of eased the communication. It also helped in building a culture of active health seeking, which was not there. So people actively would reach out to the health extension workers to ask, okay, when should they be coming from immunization? Which meant that there was increased acceptability of immunization as a service, and the involvement of traditional and religious leaders in actually tracing defaulters helped build collective oversight and ownership of the intervention. So these were some of the things to varying degrees, but had been highlighted in most of the studies that 3i funded. What this meant, interestingly, was that given all these changes that happened in the interaction between the health workers and the community, the health workers thought that it had actually simplified their work, because one of the fears that was there was that if all the additional tools that are being promoted as part of these interventions are going to add to the workload of the frontline workers. So, at least from what we see in our evaluations, the frontline workers thought that it had simplified their working, it had improved their confidence, improved their performance, and it actually freed up their time to go and reach out to more remote locations for which earlier they couldn't sort of make time. In terms of community response, the caregivers actually, once again, the community response is also based on the surveys, the key informant interviews, and focus group discussions. So what the caregivers, most of the caregivers reported using the tools, and the studies also tried to elicit if they understood better the need of immunization, the importance of timeliness of immunization, and at least the numbers that I reported in the studies seem to have moved the needle in that direction, in a desirable direction. The community leader's role was seen as important because it sort of getting the first buy-in from the community leader also meant that it was easy to sort of get the buy-in of other community members. Interestingly, we also find that monetary incentives didn't really play a role. Pretty much not pretty much, actually none of the studies, none of the formative evaluation interventions provided monetary incentives to caregivers. There were some incentives given to in a couple of studies to service providers, but none to caregivers. And the other thing that came up was targeting fathers was critical. So only Myanmar study though was the only study that tried to sort of increase participation of fathers in immunization. And some of the key areas where the studies thought the design and delivery of the program could be improved in Myanmar, and maybe Dr. Phone will talk about this in greater detail. What we find is, while there was acceptance of the intervention among the frontline workers, there was less often, towards the end of the program, the interest of higher government health workers sort of, I don't know what would be a best, but they probably thought that the community checklist was being used more as a mechanism to provide feedback on health services, and therefore they were not very well disposed to that intervention. We had issues of technological malfunctioning for the VIR bands, the vaccine indicator reminder bands that were promoted in Pakistan and Nigeria. In Ethiopia, where IRC actually rolled out calendars to remind caregivers of the upcoming health visits, the caregivers actually as a feedback mentioned that there should be emphasis on the role of men in building this care seeking, and maybe including pictorial stickers of men carrying the child to the vaccination center. And then finally, one thing that many of the studies actually struggled with was the skill and capacity of the community health workers. So a lot of this required some basic level of literacy at the frontline worker level, which wasn't there. So it meant that either the teams had to put in more effort in building capacity or had to just substitute for them and do it themselves. Finally, in terms of, and this is my concluding slide, in terms of what can be the way forward. So we at TRI really don't have any good answers to this. Like I said, that this is actually the first time that even we have funded formative evaluation. So while we have a very set way of working around impact evaluations, formative evaluations have been a learning for us as well. And some of the questions that have sort of bothered us along the way are some of these questions that we've put out. Not to say that there may not be more issues or that we think that this is the way these need to be addressed. But one thing that we realized was that probably it's important to delimit the scope of formative evaluations a little more neatly, because what we find in our evaluations is that sometimes the thrust becomes more on discussing the scalability of the intervention even before we have established well enough the doability, which should be the focus. I think scalability can also be the focus, but I guess we come to that question once we first establish the effectiveness of an intervention. Then the other thing that we've struggled with is absence of standards and benchmarks for rigor. So I don't think the researchers that we funded had a benchmark that they could be working against, nor did we have very clear benchmarks against which we could be quality assuring. So there were challenges on either side in terms of how much prescriptive we could get in providing guidance in the absence of these standard benchmarks being out there. And the third was sort of related to an earlier point about one thing that we saw in our reports was there was more emphasis on reporting out the impact or the effectiveness of an intervention, which the formative evaluations were not really set up to answer, while though the studies do talk of intermediate outputs, but not in the way probably formative evaluations should be addressing these. Secondly, I think the dilemma that faces us is around the researcher's role. So while researchers do bring innovation, I think we need to see how do we deal with the issue of researcher bias. When the researcher is both the person who is designing and implementing the intervention. So that's an area that needs more thinking. And we don't have any way forward, but we thought that this is a group which could probably brainstorm on it. And the other thing that we thought was, so even if in a scenario where a formative evaluation shows the intervention to be acceptable and feasible, we know that the researchers have played an important role in designing and implementing that intervention. Now, how do we take the researchers' role, which was limited to 3 villages, and replicate it for 100 or 300 villages to do an impact evaluation? So, who compensates or who comes in for the role that the researchers have been playing in a formative evaluation? So, those are mostly my concluding thoughts, and I'll hand it back to Mark.
So with that, yeah, I'd like to jump in with some questions for the panel, just building off of the points that Stuti raised at the end there. So it'd be good to get everyone's perspective on all of these questions, but as before, I'll kind of direct them to someone initially. So maybe Ngozi could address this first question of, for impact evaluations, there are well-established traditions and practices and standards for what constitutes rigor, and how to ensure that, whereas for formative evaluations, it's not that there are no such standards or resources, but they're just a lot less. And so what are some of the challenges in designing and implementing really useful and high quality and rigorous formative evaluations in the absence of those kinds of frameworks?
Thank you. So you're asking, like, what are some of the challenges or what are the opportunities?
Why not both?
Okay, yeah. Thank you also for a very good presentation. I was an external reviewer for the RAE for these interventions, and I was actually very impressed with the way that the researchers tried as much as they could to really document the processes that they were going through. I think that's a very good start, understanding the researchers' reflections as well as their ability to be reflexive within the intervention or within the formal evaluation is very important, and that is a good launch pad for us to try to structure kind of process for formative evaluation. I think the RID actually provided quite a few tools that we can use to go forward with formative evaluation, like the stakeholder engagement logs. Researchers took them very seriously, very much documented the process, and that's also very helpful for future best practices. And in fact, when I think about the formative evaluation, the projects that I reviewed, I kept thinking in the back of my mind, this is a very good starting point or a good set of tools that can be used as far as the best practices. Of course, it needs to continue to be refined. I think one of the biggest probably gaps and opportunities is really trying to address the point that you said about researcher bias, and really trying to understand how can the person that designed the intervention implement it, analyze the results in a way that really is as an objective lens as possible. And we had a very good conversation about this yesterday. Researchers really don't want to be totally removed from the evaluation process, but thinking about how researchers can pair with maybe not necessarily a completely external evaluator, but someone that is part of the project, but not necessarily the PI or the person that's designing it. I think that would be a very good way forward to thinking about formal evaluation structure.
Okay. If no one else wants to weigh in on that, that's a great jumping off point for next kind of question. And maybe Hailay, you could speak to this a little bit about this question of the independence of evaluators. There's this long-standing norm that evaluators should be independent of implementers to prevent bias and that kind of thing. Whereas when you have these kinds of formative evaluations, there are a lot of reasons where it makes sense to have close partnerships, if nothing else, between researchers and or evaluators and implementers. But in this case, they're kind of the same. So maybe talk a bit about some of the challenges and what you try to do and what you think others can do to maintain that kind of independence and objectivity.
Okay, thank you. I think just to add to what has been said, the way the project has been implemented, partnering with implementing agency and the research agency, I think it was a very good idea of CRI. It's been very helpful because usually when we do as a projectors, we come up with some ideas and then we develop proposals, and even it will be very hard to implement the research project. This project, we contacted the implementing agency, which was a government organization, and we discussed about the challenges and how we can address the challenges. Although the community engagement topic was originally serious, but around that issue, what are the challenges? What can we answer? What can we develop? What kind of intervention can we develop? So, even to initiate the project, to develop, to design the questions was very important to work together. During implementation also, the stakeholders, most of the stakeholders work with the government agency, and it was easy to engage the different stakeholders and participate in different ways that they can contribute, some logistically, some technically, where would the way we implemented. So the challenges that I see because of the lack of standards was the interest of the different stakeholders, because there were diverse stakeholders, so the interest was wide. So to come up to specific issues, specific questions was difficult in this situation. Also, when we choose a type of method, probably we could have chosen like a variety of combination of methods, so that even we can prevent the bias that may happen by triangulating different sources of data. And the other question was with regard to independence. Yeah, so one thing that was also important was the critical review that we were receiving from CRI was very important. When we send reporters, we get critical review and we go back and discuss, and it served, also it was not like very standardized protocol. It was very important when we discuss among the different groups. And the findings, even the findings when we discuss it with the different stakeholders, the government institutions, it was a real-time discussion. So there was no space for the creating untrusty evidence, because we worked together, and for that I think even I would recommend such kind of approach, working with implementing agencies and different wider expertise. And in fact, one of the challenge I also say is the incorporation of different multi-sectorial, multidisciplinary expertise in the project would have also helped to solve some of the challenges that we are facing.
Okay, thank you. So, next question is a question that always comes up with formative evaluations is, how well does this very small scale pilot model what's going to happen when this is taken to scale and that kind of thing. And in this case, the researchers, the evaluators were very involved in the rollout because it was a formative evaluation, it was a very small scale pilot, whereas the next step would be that it's going to be kind of handed over to the health system to manage the implementation and that kind of thing. And so there's potentially a gap there between what's been demonstrated in terms of the feasibility and the acceptability of these programs, given the formative evaluation, and how it will look when it's actually taken to the next step. So I just wondered if you could speak to that gap and how we might bridge that gap, and how we can ensure that there's a smooth transition if these are going to be handed over to the health system to implement, how we can do that smoothly. So maybe Dr. Bone, you could start by addressing that.
Thanks, Mark. Yes, your question. And so first, I like to clarify is your question is like a scale up from this our smaller than this our formative study to the mission the scale up, and there is a gap between and how to address it. There are also the challenges also. Yes. So it is also our challenges. So I did the gap. For the gap, I like to start with the challenges. So because in the challenges, we are the formative study. That's why that is a service provider side have the some consent. So particularly at this initial level, they have some consent also. Because we use the community checklist for immunization, and our checklist contain not only the education content, but also some kind of accountability content also. So that's why from the provider side, particularly from the higher level, national level side, is that their concern is the main concern is the conflict because of this accountability content of this community checklist. So because they thought that the community members have the very low knowledge about the vaccination. So at the same time, when they check the performance of the service provider at the front line, who are well-trained midwife, so it may cause some conflict between this service provider and this community members, and it may damage to the relationship and the trust at the community level between these two stakeholders. This is one concern. But actually, this concern is also have at the ground level, frontline level also. But actually, in the practice, we can overcome. So very easy, more easier than we expected. But the problem is that at the national level. So even after the research dissemination, they have still their concern. This is one challenges and one area. So that's fine. So what they want to do is that the community checklist should be the more educational tool rather than this accountability tools or something like this. And another one is our study is not only for the community checklist, also the other side is also the provider checklist also. So that's why on the provider checklist, the provider side concern is that whether it is harmonized with their supervisor checklist, because their supervisor have also their own checklist. So that's why their concern is that it's harmonizing between these two kind of checklists, and also their another very important point is that for the scalability and the sustainability, they are concerned about the cost. And so on one side is a cost, because that in our implementation components, so we use the community volunteer. So they are based on the incentive, but not much, but so not low level incentive. Even for this level of the incentives, this national level, this service provider have a concern for their budget, for the scale up and to sustainable. And also another cost is also that this checklist, that even our checklist is paper-based, but for the nationwide distribution of this paper-based checklist, it will also affect on the cost. So they are mainly concerned with the cost. The other side is also the outcome and the impact level also. Because from the formative study, we could not show the outcome of this intervention is better or not over their standard routine education campaign. So this is also the gap area. They want to know that what are the outcomes, the impact better than our this national program current level things. So this is I think that in the summary is I think it is ownership. So this is the main gap is that sometimes there is an ownership sense on the provider side also. I will stop here and I can discuss later.
Thank you. Yeah, I just wanted to add to that. I think when you think about traversing that gap between formative evaluation and then scaling it up, I think other indicators can be considered beyond feasibility and acceptability. That might be one place to start. So, and even feasibility and acceptability can be broken down in a way that you're understanding exactly who's accepting it, and one of the outcomes of all of the formative evaluation studies that I heard really is that context is key, and context is the beauty of doing a specific intervention somewhere, but it's also the barrier of doing it somewhere else. So understanding those contextual elements of the intervention, pulling that out of the evaluation is really important, so that when it's passed over, handed over to the government or to whatever institution is there, those considerations could be really assessed and understood, and not just programmatic indicators. Again, like socio-cultural indicators are very important. And then also what you were saying about cost, Dr. Fung, is really important as well. And I think that really came out yesterday in one of the sessions about even informative evaluation, where you generally are not thinking about impact or cost effectiveness. You are able to pull out some costing elements. You can do maybe a small costing study, and it's good that your IE is thinking about this and trying to incorporate the time considerations to doing a costing study within the formative evaluation is also very important. And then just practically a transition period, from maybe there needs to be more of a structured transition period from when the researcher is handing it over. It's not just, we in research, we usually just do dissemination meetings and we write something up and we move on. If we really want to have, impactful programs that can be scaled up, that can be cost effective, there possibly needs to be more of a structure in handing that over.